Okay, Bismillah Rahman Rahim. Gentlemen, today our topic of discussion is rheumatic heart disease. Although it's a lecture, I'll try to keep it as short as possible, and I'll try my best to only highlight the most important points for this lecture. Now, rheumatic heart disease is a very important topic. This topic is going to follow you in the in pediatrics in medicine as well. Now, a few words about the um, as an introduction to rheumatic heart disease. Remember that this is an immunologically mediated disease. Okay, it's multi-system. Okay, and generally occurs after few weeks after an episode of streptococcal pharyngitis. Now, this can occur after an episode of skin infection, streptococcal skin infection, but generally occurs after a streptococcal pharyngitis and uh, and takes the form of deforming fibrotic mitral stenosis in its later stages. Okay, now remember these words that rheumatic heart disease. Now, acute rheumatic fever is one thing, and then it leads to chronic rheumatic heart disease as well. Okay, but rheumatic heart disease or acute rheumatic heart disease, it's immunologically mediated. It's multi-system involving in a scenario few weeks after an episode of Group A streptococcal pharyngitis. This is the most important point you'll get in a history when you're about to answer a question regarding this disease. Okay, remember, this is the books say that this is essentially the only cause of acquired mitral stenosis. We're not talking about congenital stuff, we're talking about acquired mitral stenosis, and this is the most important acquired cause of mitral stenosis. Okay, this is also a problem. You can see this data. This is something from the United States. This is also a problem in some of their regions as well. Now, how it happens? Remember, when there's infection by streptococcal pharyngitis, streptococcal microorganisms, the bacterium, the antibodies, the body tries to give some response, and there are some antibodies and CD4 positive cells that are activated. Okay, antibodies and CD4 positive T cells, which are directed against the M protein. This is sometimes asked in an MCQ that which is the protein or the name of the protein that the inflammatory response is directed to. It is actually directed to those M proteins, and sometimes it happens that these antibodies and T cells, they recognize self antigens in the myocardium. Now, when they now body's own immune response should not recognize its own cells. Um, but if it does, it attacks against them and starts destroying. It leads to activation of the complement system, okay, and then production of cytokines and leading to macrophage activation. This is how the inflammatory response goes on when we talk about rheumatic heart disease. Clinical findings are very important. There is a criteria that is known as the Jones criteria that is utilized to help us in diagnosing this disease. But remember, we should have a laboratory evidence, an important laboratory evidence is the serological evidence, that is the antibodies. These are the antibodies, anti-streptolysin O and anti-DNase B antibodies, which are directed against the infection. Okay, we talked about it in the introduction in the definition that it's an immunologically mediated disease. Therefore, we try to detect some antibodies, and these, the highlighted ones, are the most important antibodies: anti-streptolysin O and anti-DNase B antibodies. And then the clinical criteria Jones, J is for joints, okay? And by joints, we explain it as that it's a migratory polyarthritis. What does migratory polyarthritis mean? It means that one large joint. Migratory means migration, and polyarthritis means that involvement of multiple joints. Now, what happens in rheumatic heart disease is that multiple large joints, they get involved, but one after another, with resolution inflammation gradually in the previous joint. Okay, Then O stands for, we try to remember that O is the shape of the heart, kind of. Okay, so it's carditis. Then, so J is joint, O is carditis, N is for nodules. What are nodules? Subcutaneous nodules. E is an erythematous annular rash on the skin, and then S is symptoms chorea, which is defined as involuntary rapid purposeless movement. So remember the JONES, the Jones, and you can kind of remember with this, with the help of this, um, what's the explanation. Then fever, arthralgias, and acute phase reactants, increased DSR, etc. Um, what we say is that, um, how do we write it? As if somebody asks you to write the criteria, gives you a scenario, asks you to write the criteria, you write that you should have a serological evidence of previous infection with two or more of the Jones criteria. Okay, at least of these five, two or more should be present in addition to these antibodies. Okay. And when we talk about fever arthralgias, one major and two minor criteria at least should be present. Okay, one major, this is the major one. Okay, and two minor. Now, first attack usually occurs during the ages of 5 to 15. So this is the most likely age group, or 5 to 15 or 20, around 20, 22. These are the most likely ages you're going to get. Most likely, I'm saying, it's not definite thing, but most likely you're going to get these ages. Second point, one large joint after another becoming involved. It becomes swollen, it becomes painful. Obviously, there is some inflammatory activity going on, then it subsides spontaneously. Okay, but there's some chronic damage that's going on inside the body. And then pericardial friction rubs with involvement of, we said that it's a multi-system disease. Pericardial friction rubs, tachycardia, arrhythmias can also occur, and valve damage also occurs in the chronic stages. It does occur in the acute stage as well, but the manifestations are mostly chronic. Now, when we talk about morphology, this shows the gross morphology of an affected valve. We're talking about rheumatic heart disease in particular. This is an affected valve. These are the chordae tendineae, and see, if you look closely, these have kind of become thickened and joined to each other. These are separate, this one separate, this one separate, but these have joined. The inflammatory activity has occurred here, and these ha- and this has gone into the chronic stage, and this these chordae tendineae have fused. These small raised areas are known as the vegetations, or verrucae as they're called. And if something like this is sampled, this is how it looks like. Now, this circumscribed area within the myocardium, uh, I'm sorry, this one is the valve leaflet, and this one is a section from myocardium, because you can see here, you can see these are the myocardial fibers. Now, this area is something that is known as the um, uh, Aschoff body. Okay, remember the word. This is called an Aschoff body, and this is comprised of activated T lymphocytes and a few other larger cells. There may be some plasma cells as well, and the larger cells are important because they're known as the NHK cells, and these are activated macrophages. You can see one here, um, this one. These are larger cells which have some prominent nuclei. Okay, so this is the important points regarding the morphology: the Aschoff body itself, the word, and then the NHK cells, the lymphocytes, and the plasma cells. Now, what happens chronically? A lot of things go wrong with the valves. Now, when an extensive inflammatory activity is going on around the mitral valves, in the heart, when acute inflammation, it is not controlled to the extent that it's completely removed and the offending agent is completely removed. That's one consequence. But another consequence is that it leads to fibrous scarring, and that's what happens in rheumatic heart disease. You can see here the mitral valve leaflet has gone. It's fairly narrowed. Okay, in this area, this cannot function properly, and in this region, you can see that this is a removed specimen from the patient, and this has become whitish and fibrotic. So this is a consequence of chronic rheumatic heart disease. Remember that most important functional consequences of mitral valve disease, because of what we've discussed, that leads to fusion of chordae tendineae, stenosis, calcification, narrowing, etc., valve stenosis, and regurgitation. If somebody asks you what are the two most important functional consequences of this disease, these are stenosis and regurgitation of the valves, in particular the mitral valve. Okay, so these are the references for today's discussion. Um, if you have any questions, kindly let me know. Signing out for now.